Yeah, Shilpa madam, we are live now.
Yeah, hi. Good evening, everyone. So today's topic is what to do when we come across a situation wherein the specimen of the hysterectomy in the histopathology says endometrial carcinoma. How do we go about it? Because I think these kind of situations every gynecologist would have faced once or twice in their lifetime, however cautious they are pre-surgery evaluation. So we will know practically how to deal with it, and then we will take home some practical points so that we try to prevent this kind of a situation happening. But in spite of having all the precautionary measures, if it still happens, we should know what to do about it. Yes, I mean, Dr. Jay, you can take over.
Yeah. Hi guys. I'm live from Bombay Airport, and it's a beautiful airport. Let me tell that to you. So I'll start with the screen sharing because for this, okay, one, two or three important points on what Shilpa madam mentioned. Okay, and the first thing, this is not a very uncommon thing, as madam mentioned. Okay, very important actually understand that not all people would do an endometrial biopsy for the patient prior to posting her for hysterectomy. Okay, but you should remember that if the endometrium is thickened for a particular age, then it is ideal to at least put a color Doppler before you do a hysterectomy. Okay, this will really help you reduce the incidence of this happening. Okay, but now I will start the screen sharing. Shilpa madam, I'm audible, right?
Yeah.
Okay. So I have made this. I have made this sort of a nice flowchart, okay, which I thought I will share with everybody, okay, on this thing. So just opening the laptop. Yeah. So here we go. See, the most important thing, please try and understand. Okay. So you have done a hysterectomy, okay, irrespective of the route. It's abdominal, vaginal, it is laparoscopic hysterectomy. Whatever hysterectomy you have done, and you have a histopath report. Okay, this is the exact flowchart which I have in my hospital. So I'm drawing the same thing. It's suggestive of CA endometrium. Okay, so now there are certain important things which you need to look at this CA endometrium. Okay, do not confuse yourself with anything. Okay, grade 1, grade 2, grade 3, stage 1, stage 2, stage 3. Don't try to think of it like that. Okay, the simple analysis which you should run in your mind is this: is it a low grade malignancy? Is it a high grade tumor? Okay, simple. The most important thing, when you get this HPE slide demonstrating cancer endometrium, if not done by an oncopathologist, just get it re-verified by an oncopathologist. That is the first thing. After the oncopathologist tells you low grade, high grade, okay, then you look into the other type of things, which is age of the patient, myometrial invasion, size of tumor, lymphovascular space invasion, and free margins. Just please keep this much in mind. Okay. So what is going to happen is you are supposed to disclose this entire detail to the patient after the hysterectomy has been done. The patient is going to come and sit in front of you in your cabin, irrespective of the route which has been chosen. And usually the patient is going to come back to you after a hysterectomy within 2 weeks. So let's say 14 days of surgery. Okay. The only thing which we should keep in mind primarily in our head, of course, I'm really breaking it down into the simplest possible details. Okay. And I will normally divide it into two parts. Okay. Oophorectomy, not done. Okay. In the primary surgery, or oophorectomy, done. Okay. Just these two categories. Do not try to confuse into anything else. If the oophorectomy is not done, then irrespective of low grade or high grade, Okay, irrespective of everything else, you will require repeat laparoscopic surgery or completion. In that, you are supposed to mandatorily do BSO plus pelvic lymphadenectomy. Do not think of anything else beyond this. No chemo, no radiations, no thinking that okay, I'll leave the ovary behind, I'll give GnRH agonist, I'll leave the ovary behind, I'll give dynogest. No bakwas. Okay, just simple. If oophorectomy is not done, repeat laparoscopic completion surgery. You are supposed to do bilateral salping oophorectomy plus pelvic lymph nodes if indicated. And in most of the situations, if the age of the patient is usually more than 60, myometrial invasion more than half of the thickness, more than 50%, size of the tumor more than 2 centimeters, lymphovascular invasion presence and free margins negative, and if it is high grade tumor or low grade tumor, with any of these, you have to do a pelvic lymphadenectomy. And discuss the sentinel and the sentinel lymph node without the flowchart because we don't have sentinel in our flowchart. Okay. If the oophorectomy of the patient is done, then you divide it into two grades. Okay, that means hysterectomy has been done and bilateral salpingo-oophorectomy has been done. Of course, let me just write down bilateral at both the places because that is important. If hysterectomy plus bilateral salpingo-oophorectomy has been done by the doctor and if it is a low-grade tumor, okay, then simple, take opinion of medical oncologist, okay, PET scan after 6 weeks and strict follow-up. Remember, in oncology, it is never going to be a gynecologist or a gynae oncosurgeon alone. It is a team. Medical oncologist, radiation oncologist, gynec oncosurgeon. So what we have in our hospital is something called as a small tumor board. Okay, I'll come to how to form the tumor board, how to include people, how to cut down your ego, and how to listen to everyone for the benefit of people. Okay, if it is high grade, okay, then do not think. If it is high grade, then kindly do a repeat laparoscopic surgery for pelvic lymph node. And based on that, you decide further. Now, please remember, when it is high grade, bilateral oophorectomy is done. Along with pelvic node, we normally take a vaginal cuff as well so that we get something called as free margins. Okay, this is the most simplest flowchart which I can give you in order to deal with this case. Just by heart this, okay? And if you are able to by heart this thing, every time when you have a situation where something like this has happened, okay, and the patient has presented to you, instead of being surprised as to what needs to be done for that particular patient, you will have a steady flowchart in your head and you will be able to take a call. All right. Now, one important point, can you avoid a circumstance like this in any situation? The answer is very simple. In order to avoid this, if it is a postmenopausal lady and the postmenopausal lady is going to have an endometrial thickness of more than 4 to 5 millimeters with Doppler positive, all right, then kindly, okay, ensure that in that situation you are doing an endometrial biopsy. If it is a premenopausal having a persistent early menstrual thickness of more than 14 millimeter, persistent early menstrual, first 10 days of the menses thickness of more than 14 millimeter, please biopsy that endometrium prior to taking the patient out for surgery. Very simple rule. All right. One common thing which people often miss out and which is what we see the most common. Okay. The specimen, once it is taken out, it is cut and chopped into many pieces. And once the specimen is taken out, it is sometimes removed by morcellation. Let's say a laparoscopic surgery, large uterus, 20 weeks was there. There is a focus of CA endometrium, which has been, the specimen has been morcellated, and you have been told few tiny foci of high grade malignancy seen. Okay. Here comes the role of primarily doing the entire staging of this specimen, of a specimen, by a pathologist. Okay, so when a pathologist does the grossing of this specimen, and if he's good at doing grossing, he will identify those cut sections. Once he identifies those cut sections, he will prepare good slide and block, and a repeat assessment is going to be easy. But when you are in doubt, let's say things are not clear, okay, don't really know what was done, what was not done. Please think of it as a high grade lesion and please do a repeat surgery. When you think your details are not correct, this is the flow chart I presented is if the details are correct. So if your details are not correct, please, okay, think of it as a high grade and operate. Okay. And this is something which you should probably take home. With this, I finish my presentation. I'm open to questions from Shilpa madam.
Yeah. So you told age-specific endometrial thickness. I mean, what do you mean by that? Is it just premenopausal and postmenopausal, like you said, 14 mm and postmenopausal 5 mm, 8 mm with symptoms, without symptoms? Is it like that? Okay. Yeah. So you told about how to prevent it is by doing endometrial biopsy. What are the precautions you take
and
during
adding
the surgery?
Doppler.
Under Doppler, yeah. So what are the precautions you take during your laparoscopic surgery when you're doing a hysterectomy to kind of avoid like using myoma screws or doing all sorts of things? I mean, what
if anybody has had some training into oncology, they will understand the importance of using a no-touch technique for almost everything. Okay. So I am not saying that people who are using myoma screw are doing something wrong. I do not know. I do not probably think that way. But all I'm trying to tell you is we do it as a standard approach. If anybody has ever seen me do a hysterectomy, there is no manipulation, right? I have no intrauterine manipulation. I have no myoma screw manipulation, nothing. So what typically happens is the serosal margin almost never gets breached, right? Out of maybe 1,000, in one case, my needle holder will poke inside. Otherwise, I use the round ligament to give traction. So what typically happens is that when you are probably standardizing your benign hysterectomy, with an oncologic point of view, you've already avoided a lot of things. Okay, that is the first thing. Second, in a postmenopausal lady, if you have a bulky uterus, remember this thing. In a postmenopausal lady, if you have a bulky uterus, do an inverted colpotomy and try to take out that specimen intact. Okay, do not cut and chop that specimen and take it out piecemeal. Do an inverted colpotomy. We have shown this on Facebook multiple times, and try to take out that specimen intact so that your pathologist can gross it nicely.
Okay. You're done with that question? Yeah. What about uterine manipulator? That should be okay, right? I mean, if people are using uterine manipulators.
I think so, madam.
Yeah.
I think it is okay.
Yeah. So you said while doing a PLND, as in like pelvic node, the dissection and excision. So you said you will do a vaginal cuff also as a repeat surgery. Okay. But if the margins are free, would you still want to do the vaginal cuff?
Yeah, madam. The reason why I'm saying that I'll do a vaginal cuff is because in a lot of situations, okay, the recurrence which occurs is usually a vault recurrence for any of these patients. Okay. So if you take this free 2 centimeter margin of the cuff, see, it is not a guideline. Okay, it is not a guideline. Please let me tell you, apart from lesions involving the cervical stroma, it is not a guideline. Okay. For primary endometrial lesions, it is not a guideline. But we do it because out of our experience of doing quite a lot of these cases, the commonest recurrence is there. So ever since we started doing vaginal cuff excision, the recurrence rate is virtually nothing. Okay, on long-term follow-ups.
No, but see, vaginal cuff removal is like, I mean, very tough in a post-hysterectomy case where you have to do the dissection of the bladder, dissection of the posterior aspect of the vault.
I get your point. I do get your point, madam. But one of the easiest ways to do a vaginal cuff excision is simply going to the parametrium, lateralizing the ureter, pushing the bladder down, like how you would do in a radical hysterectomy. Okay. And for people who are used to doing it, I don't think it is a tough thing, madam.
Okay, and tell me this. I mean, you didn't divide or say anything about non-gastro tumors or the clear cell and all those things. So
Yeah,
you think it doesn't really matter what kind of the endometrial cancer it is?
I actually mentioned. I mentioned if it is a low grade or if it is a high grade. So any of these clear cells, serous cells, atypical tumors, all of this would be classified as high grade tumors. Malignant tumors of Mullerian anomalies of mixed malignant tumors with sarcomatoid as well as carcinomatoid changes. All these high
Mm.
grade tumors, it is only going to be the endometrioid version of the adenocarcinoma of the endometrium. Okay,
Mm.
adenocarcinoma endometrium when we try to call it that way. But
Mm.
apart from that, when you are talking of clear cell tumor, let's say, or papillary serous tumor of the uterus, basically of the
Mm.
endometrium, it is a high grade.
Mm.
You don't really have to say a low grade papillary serous. It's a high grade. It has to be treated actually
Mm.
like a CA ovary. So
Yeah, yeah. Okay. So, see, coming to vaginal brachytherapy, see, I see this very often when patients, they come with the biopsy report of see endometrium where they have had a TAH with BSO, and they are not, and it is like more than half of the myometrial invasion. So, and there are like 2, 3 other risk factors, and they are not willing to go ahead with the surgery. They just want to directly
yeah,
ask whether they can go for vaginal brachytherapy.
yeah.
So what is your thought on this? I mean, can we skip that second surgery and directly go for brachytherapy?
See, madam, whenever you have more than 50% myometrial invasion, I mentioned that as an
Hmm.
important point. In that
Yes,
situation, you are exposing the lateral pelvic wall to a recurrence unless
yes.
you do a pelvic lymphadenectomy from there. Okay.
Hmm.
So even if you
Hmm.
give vaginal brachy is going to act maybe 1.5 to 2 centimeters away from the cuff. So local,
Correct.
very local. Understanding, you are not
Hmm.
going to reach the lateral pelvic wall. And
Yeah.
believe me, people who have not seen lateral pelvic wall recurrences can speak all big, big things. But the first time
Yeah.
you see a recurrence, it will be a lymph node which is encasing the common iliac vessel, right?
Yes.
It's
Yes.
inoperable. Okay.
Yes.
And
Yes.
in that situation, why to give a patient a double modality? Why give a radiation therapy along with a surgery rather than
Yes.
simply keeping it to one modality? Okay. And finishing it off
Yeah.
by counseling the patient properly for a second surgery.
Yeah. So, in the second surgery, you do a pelvic lymph node excision and then you send it for testing. And if the nodes come positive, so instead of the
Yes.
vaginal brachytherapy, you are going to advise them to take the external beam radiotherapy, isn't it? I mean, is that the way
and
how it
and
goes?
chemotherapy. Yeah,
Yeah, and
because once
chemotherapy.
the pelvic nodes are positive, it is
Yeah.
madam directly stage three, and in
Yes.
stage
Yes.
three, to avoid
Yes.
recurrence, it is going to become, mm, it is going to be chemotherapy plus radiation therapy, right? But
Yes.
what
Yes.
is important to understand is if your pelvic nodes are negative, okay,
Yeah.
ideally you should have around more than 8 to 9 nodes per side,
Yeah.
and if your
Mm.
pelvic nodes are negative, okay,
Mm.
you have given that patient an option to only do a follow up. That is one. You have given that
Mm.
patient a second option that if there is a local vault recurrence, you can then put her to radiation on follow up. Okay. Rather than doing the surgery, because once you do a radiation there and then there is a local recurrence, then you
Mm.
are exposing the patient to a higher line of radiation after that,
Mm.
a wider
Yeah.
beam. Why should one
Mm.
do that, madam?
Mm. 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 Correct. Correct. So, which are the situations that warrant frozen when they are doing the hysterectomy? So forget about the common scenarios where there is a doubt and all that. I mean, where do you think the role of frozen is in these kind of situations to be avoided? Surprises.
Bulky postmenopausal uterus. First,
Mm,
do a frozen. Okay. Any
mm,
multiple myoma patient where you are doing hysterectomy, do a frozen
mm,
because
mm,
you will be surprised to find stump. You will be surprised to find, high mitotic index somewhere. All these things will come in that type of
mm,
situation. So I think,
mm,
see, we have invested in a frozen facility, okay,
mm,
since I think quite some time now, 7 years. So we have it in house.
mm,
But then people
mm,
who don't have it in house should call people to do it at their unit or at their hospital premises and get it done, madam.
Yeah, I think yes. So, what do you think the frozen? I mean, what is the accuracy of frozen? See, many people, because of the cumbersomeness of the whole thing, they try and say it's okay. I mean, let's not do it. So, they tell the patient that no, I mean, it may not be as accurate as the actual histopathology. So, in your experience, how has the correlation been with the actual biopsy and the frozen?
Madam, if Rajnikant and Dhanush were to act in the same movie, same script, okay, you will choose Rajnikant, no, to become the distributor. It's just like that
Yeah.
in Frozen. It is the person who does the Frozen for you, madam. There are so many people who are so good at doing cytology Frozen. I've seen that
Mm,
because I have those people in my team. From
mm,
the surface of the serosa, they will scrape it and put it on the slide. Okay, that is sort of a
mm,
side of Frozen.
mm,
Then they forward it with a cryotome. They cut it with the cryotome. It's a machine. Simply, it will just freeze the tissue, and you once the grossing is done, it will cut it into small parts, and then they'll stain, and then they'll see. Okay, so uh,
mm, mm.
I think, okay, that is the biggest asset I have in my team as a small unit doing gynae oncosurgery. A guy who does
Mm,
superb pathology. It's impossible.
mm.
It is impossible to progress in oncosurgery uh, without a good pathology colleague.
Yeah, I agree on that. Uh, yeah, I think most of it we have covered. So, tell about this common situation where fertility patients who are gross PCO who come with endometrial atypia, uh, endometrial hyperplasia with atypia, and then you kind of do a hysterectomy, and then not infertility, but when you see that like the atypia is not really good and the endometrium is really bad and you want to do a hysterectomy and you do it and then you get a focal well differentiated carcinoma. So
Yeah.
those things I don't think we need, just tell about how do we tackle that.
See, if it was to be my sister, I will remove that uterus. It is simple. Because today you have a
Mm,
focal lesion at one point. Tomorrow you will have a
mm,
focal lesion at some other point. Okay. I
mm,
do
mm,
understand there are people who write big things on WhatsApp groups about giving progesterone long term high dose therapy, and then patient will become pregnant with an embryo transfer and all these things. But you are exposing that lady to a risk of malignancy which will ultimately kill her. And I don't
yeah,
really think it is worth it. Okay, this is my
yeah.
opinion. Okay. I I'm not the head of an oncosurgery mega unit making guidelines, but this is my personal opinion. Okay.
Yeah, so I think we are good. So the main point is like whenever you have a suspicion, like when whatever high risk situations, try and do a complete hysterectomy with salpingo-oophorectomy. And if at all, if it comes out as CA, then depending on the grading, just go ahead and do the pelvic lymph node excisions. And based on that report, even if one of the nodes comes positive, then go for radiation. So don't skip the step of doing the second surgery and go for radiation, either brachytherapy or external beam radiation. Isn't that the whole gist of what you said? Is there anything you would like to add?
Yeah, I would just like to say that any of the adjuvant therapies to a surgery, be it external beam radiation or brachy or whatever, okay,
Mm,
is
mm,
best decided by the radiation oncologist. Okay, what field they
yeah,
want to irradiate, how much they want to irradiate,
yeah,
and when they want to
yeah.
do it. It is their call. To be honest with you, so
Yes.
I really don't give a guideline like that. I always, as I mentioned, even in writing on the flowchart, that if there is
Mm,
something like this, and if we are not doing anything, on paper opinion for a medical oncologist will
yes.
come that
Yes.
even
Yes.
he thinks that we should not do anything, right?
Correct.
And I think that helps from the medical legal perspective.
Yes. So that's a very important point where the involvement of oncologist will definitely be a very, very important step in managing these kind of situations. However good we are as gynecologist, or however senior and so much of experience that we still have to involve an oncologist and have a written say prescription or a letter saying what needs to be done. So how frequently do you follow in case if you need to follow without doing anything, and for how long do you follow for the rest of their life?
Normal follow-up, no, madam. Normal follow-up is for the first 3 months. Every 3 monthly for the first 1 year. And then
Hmm.
usually it is between 6 months to a year for the next 2 to 3 years. Okay.
Hmm.
If
Okay.
you want to
Yeah.
pick up something, we'll pick up in that time.
Yeah. Okay. Yeah. Thank you so much. Thank you. It was wonderful. So have a happy journey to Hyderabad. Have a happy surgical day tomorrow, day after with your list. Have a great day. Bye.
Thank you, madam. Bye bye.